بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, this is the second part of the topic of intensive care radiology. And in the first part of this talk, we have discussed most of the tubes and catheters, and also the lines used for patients inside the intensive care unit. And there are two only remaining devices. I will mention them now. Then we'll continue with the discussion of the possible lesions that can occur in the lung, in the pleura, and in the mediastinum for those who are in the intensive care unit. This is one of the two devices, which is the Swan-Ganz catheter or the pulmonary artery catheter. It is used to measure the pulmonary capillary wedge pressure and to monitor the circulatory hemodynamics. And sometimes it can help to differentiate between cardiogenic and non-cardiogenic pulmonary edema. The catheter is an intravenous catheter inserted usually through the subclavian or the internal jugular vein, and the tip of the catheter is pushed until it is in one of the main pulmonary arteries, either the left one or the right one. And the ideal position of the tip of the catheter is about 2 centimeters from the hilar shadow, as judged by the plain X-ray. Then, in order to measure the pulmonary wedge pressure, there is a balloon at the tip of the catheter, and we inflate this balloon whenever we are going to take measurements. Then, if the balloon is advanced too much beyond the pulmonary artery bifurcation, or if it is left inflated for some time, then the catheter may result in occlusion of the pulmonary artery and the development of pulmonary infarction. If the catheter is pushed to distal, if there is persistent inflation of the balloon, or if there is a blood clot that has been formed around the tip of the balloon, this will occlude the corresponding branch of the pulmonary artery, which will result in pulmonary infarction. This is the Swan-Ganz catheter, and you push the catheter into the right or the left pulmonary artery, and the tip should be within 2 centimeter distance from the hilum. And you can feel now that the tip of this catheter is a little bit far distal from the usual position, and it needs to be judged. This is, as you have known that the plain X-ray of the chest plays an important role to judge the position of the catheters and the tubes, and also to see the possible complications. Then this is a good position of the Swan-Ganz catheter tip, and you see the tip is here, which is in the range of about 2 centimeters from the hilum. Then what are the complications of the catheter? They are similar to the central venous line complications, including misplacement of the catheter, either too far or here from the usual position, looping, coiling, or knotting, pneumothorax due to injury of the pleura while introducing the catheter, vascular injury, either the vein or the adjacent artery. And these are considered rare complications, but they are potentially fatal, such as the development of pulmonary artery rupture, a pulmonary dissection, and the development of pseudoaneurysm or a rupture of the balloon of the catheter with development of pulmonary and the bronchial artery fistula. Then if you look here for the tip of the catheter, and you see the catheter is positioned in the right ventricle, then this is the catheter has pushed into the right atrium, then to the right ventricle. It has to be pushed one more until it is in the left or the right pulmonary artery. And this is a good position of the tip of the Swan-Ganz catheter, and this can be accurately judged by the plain X-ray. Now we came to the last instrument, which is the pacemaker, cardiac pacemaker. And we have two types, the temporary and permanent cardiac pacemakers. And they are usually used to treat some of the problems related to the cardiac contractility. Then the transvenous insertion of the leads of the pacemaker is a preferable method for patients in the ICU. Then the leads are inserted into the internal jugular or the subclavian vein as like the Swan-Ganz catheter and central venous lines. The pacemaker is composed of a pulse generator, which is a battery pack and the control unit. This is the pulse generator, and lead wires with electrodes for contact with the endocardium or the myocardium. These are the leads, and there are double lead pacemaker and triple lead pacemaker. They range from single lead to complex device with multiple leads. The typical pacing include two leads, one in the right atrium and another one in the right ventricular apex. Biventricular pacing or cardiac resynchronization therapy can be used to treat congestive heart failure. Left ventricular pacing may be added via the coronary sinus to stimulate the left ventricular myocardium. And this is the regular cardiac pacemaker with two leads. One is placed into the right atrium, and the second one is placed into the right ventricle. And this is also the dual pacemaker, where one lead is located in the right atrium and the other one is located in the right ventricle. And this is the three leads pacemaker, where another lead is added to the inside the left ventricle. Then in this case, you see that this is the pacemaker and is introduced into the left subclavian vein, and the pacemaker leads are present in situ. Sometimes the patient may have two pacemakers, one to stimulate the heart and the other to stimulate the brain, which is known as DBS or deep brain stimulator. At that time, one of the pacemakers should be located on the left side and the other one is put in the right side in order not to interfere with each other. Then the complications of pacemakers are like the previously mentioned with swan gas, the development of pneumothorax and vascular injury while inserting the electrodes. Myocardial perforation is uncommon, and the perforation may result in pericardial collection and the development of cardiac tamponade. Sometimes the lead is fractured, and the rate of this complication is up to 4%. Lead fracture commonly occurs due to compression of the lead between the clavicle and the first rib. And this is just an example of a kink of the lead at the mentioned area between the rib and the clavicle. Then one of the complications of insertion of the cardiac pacemaker is the development of pneumothorax. A pneumothorax, if it is small, it can be missed, especially that the chest X-rays obtained in the ICU are not of a very good quality. Then whenever possible, if you are suspecting this complication, you may have the inspiratory and expiratory film that can help in identification of a small amount of pneumothorax, like in this case. And this is the inspiratory film, and here the expiratory film, where you can see the pleural edge, and you can elicit the presence of small amount of air at the apex of the left lung. But massive pneumothorax like this one can be easily appreciated in the regular frontal chest X-ray. And this is one of the complications that the lead has present outside the confinement of the cardiac shadow, which may indicate that there is some perforation of the myocardium. Also, the pacemaker generator may erode the skin, like in this case. And actually, there are some of the predisposing factors that can lead to this complication. These factors include extremely fragile skin of elderly patients. The surgical bucket was small. The subcutaneous fat is scanty. The chronic use of corticosteroids or the use of abrasive disinfectants, which may injure the skin and lead to this complication. Now we are going to discuss the possible abnormalities that can occur in the lung, in the pleura, and in the mediastinum, since we have finished the discussion of the tubes and lines. Then these are the tubes that we have described, and we mentioned the complications of each of them. The endocardial tube, the tracheostomy tube, intercostal tube, nasogastric tube, central venous line, Swan-Ganz catheter, and cardiac pacemaker. Then pulmonary lesions we would like to discuss are atelectasis, aspiration, pneumonia, edema, acute respiratory distress syndrome, barotrauma, and the lung abscess. The pleural lesions we would like to discuss are the effusion, pneumothorax, hemothorax, and mediastinal pathology. Would like to say something about pneumomediastinum, pulmonary embolism, superior vena cava thrombosis, aortic dissection, and the cardiac tamponade. Then the pulmonary lesions, as I have mentioned, they include atelectasis, aspiration, pneumonia, pulmonary edema, acute respiratory distress, embolism, abscess, and barotrauma. This is a research series which came to a conclusion that there is no increased adverse outcome in patients who did not undergo routine daily chest radiographs versus patients who did. That is to say that it is not essential to do as a routine a daily chest radiograph for the ICU patient, and it is only reserved for real indications. We start first by atelectasis. Atelectasis is the most common cause of lung opacity in ICU patients. Then, if the atelectasis involve part of the lobe of a lobe, it is known as atelectasis. If it affects a whole lobe, it is known as lobar collapse. And atelectasis in the ICU patient may be due to gravity dependency, obstructive atelectasis, passive atelectasis, compressive, adhesive, and cicatricial. Adhesive atelectasis is commonly secondary to decreased surfactant and commonly seen in patients with acute respiratory distress syndrome, while cicatricial atelectasis is a chronic form resulting from scarring in the lung, possibly due to previous infection. Then these are the most common sites of atelectasis. The left lower lobe is the most common site, then the right lower lobe, then the right upper lobe. Atelectasis means that a part or a part of a segment of a lobe that is affected and is collapsed. And you remember from the early days where the plain film was the only available modality for evaluation of intrathoracic abnormalities, we have been taught that the direct signs of atelectasis, meaning the loss of volume, and with resultant displacement of the fissure, crowding of the ribs, and it can be ill-defined, similar to a pleural effusion if it is present near the costophrenic angle. Then this is the lower lobe collapse, and we have agreed that if atelectasis affected a lobe, then this is called lower lobe collapse. And this is the lower lobe because of the silhouette sign. You can see the right cardiac border clearly through the opacity, meaning that the opacity is located posteriorly, and all posterior opacities in the chest are located in the lower lobes, whether they are on the left or on the right side. And this is another example of two areas of atelectasis, one in the upper lobe and one in the middle lobe. And this is what we call thick plate of atelectasis or thick atelectatic bands. They are seen clearly in the frontal view, but they are not well appreciated in the lateral view. But in the lateral view, which is not a common X-ray technique obtained in the ICU, you can see a small pleural effusion with obliteration of the posterior costophrenic angle. Then here you see the atelectatic bands by CT, very thick atelectatic bands in the lower lobes. And if you look here and you see that there is a patchy opacity on the right side with partial obliteration of the cardiac silhouette, meaning that the opacity is anterior. And the anterior structure present here is the middle lobe. And if you look in the lateral view, then you will see that the opacity is projected in the middle lobe, and this is middle lobe consolidation. But whenever you appreciate the degree of loss of volume as detected by the displacement of the fissures and the actual loss of volume of the middle lobe, then you know that this is a consolidation with partial atelectasis. Then, if you have the CT scan, you can see bilateral pleural effusion with underlying compression, consolidation of the lower lobes with internal air bronchogram. According to the literature, they said that atelectasis will enhance with contrast material more than the enhancement of the muscles, while the consolidation will enhance either similar or less than the skeletal muscles. And if you inject contrast and mnemonic consolidation does not enhance or did not enhance, then you know that this is necrotizing pneumonia. As you see here in this example, in the bilateral pleural effusion, there is contrast material injected as seen in the aorta, and you see the enhancement of the atelectasis and the relative non-enhancement of the pneumonia, which is diagnostic of necrotizing pneumonia. And aspiration is one of the commonly seen findings in patients in the intensive care units. And the incidence of aspiration is increased, especially with decreased conscious. Then we have three types of aspiration. Aspiration pneumonitis, which is subtle changes in the lung, usually do not require treatment. Aspiration pneumonia, which is similar to other types of pneumonia, and it requires antibiotic therapy. Then aspiration of inert or non-toxic substances. In pneumonitis, as I have mentioned, it requires no treatment, but pneumonia requires antibiotic therapy. Severe aspiration can lead to acute respiratory failure, can lead to sepsis or acute respiratory distress syndrome. The incidence of aspiration pneumonia represents about 5 to 15% of all community-acquired pneumonia. The risk of aspiration includes the obesity, advanced age, periodontal disease, neurogenic disorders, altered conscious level, and functional dependence in activities, and various gastrointestinal conditions. Then this is an example of an 80 years old female with aspiration event few hours before presentation. Then the initial chest X-ray showed bilateral opacities in the lung bases. The next follow-up showed clearance of the right basal opacities, but persistence of the left opacities. The next follow-up showed progression of the left basal opacities with obliteration of the diaphragmatic contour and some fluid in the costophrenic angle. The final follow-up showed clearance of both opacities with clearance of the costophrenic angle. And if you look to this chest X-ray, and you see dense opacity, which is aspiration pneumonia. Not pneumonitis means just hazy and reticulations of the area affected by aspiration. But this is true consolidation, and it may show sometimes air bronchogram. And aspiration may not be detected in the chest X-ray in up to 10% of the cases. And many times, if you have the chest X-ray, you can see multiple patchy areas of consolidation. And also, if you have the CT scan, you may see a common form or in a well-known form of consolidation or opacities in the lung, which is known as the tree or bud appearance. Then, if the aspirate has obstructed one of the bronchi, it may lead to loss of volume of the affected part of the lung. In aspiration pneumonia, and this is aspiration pneumonitis, usually may progress in the first day, then starts to clear in the following days. But progression of the consolidation is an indication of the development of pneumonia. Aspiration usually occur in the posterior segments of the upper lobes if the patient is recumbent, and also in the superior segments of the lower lobes and the basal segments of the lower lobes. It is well known that CT is much more better than X-ray for detection of early and subtle events of aspiration. In this example, CT also helped to detect the aspirate within the bronchus, as you can see here, and the consequent consolidation of the lung. And this is the appearance in the plain X-ray with patchy, ill-defined pulmonary opacities on both sides. And the CT showed the classic tree in bud appearance with small alveolar nodules and some reticulation of the pulmonary interstitium. Pneumonia is one of the known events in a patient with in the intensive care unit, and we have some definitions of pneumonia commonly used in especially in emergency practice, where the first is the community acquired pneumonia, which is pneumonia in patients admitted to the hospital from home, and it develops in the first 48 hours of admission. This is known as community acquired pneumonia. Then healthcare associated pneumonia is a pneumonia in an already hospitalized patient within 30 days. Oh, then the third terminology is the nosocomial pneumonia, which develops 48 hours after admission and commonly seen in the ICU patients. Nosocomial pneumonia in patients on ventilation is known as ventilator-associated pneumonia. The incidence of nosocomial pneumonia in ICU patients is about 7%. Then, according to the literature, they indicate that the presence of central areas of breaking down or cavitation is one of the supportive diagnostic signs of pneumonic consolidation. But you know that the presence of opacity with air bronchogram and obliteration of the adjacent landmarks in the chest together with the known silhouette signs and maybe the presence of some pleural effusion are some of the supportive criteria. Patchy areas of consolidations are usually seen in the lung, either unilateral or bilateral. Air bronchogram is one of the well-known features of pneumonic consolidation, and cavitation can occur and is a more specific finding of pneumonia, as I have mentioned. Then pneumonia it changes a little bit slow than in atelectasis and aspiration and lung edema, meaning that the follow-up of a pulmonary opacity that is secondary to aspiration is rapidly changing compared to the opacity secondary to pneumonic consolidation. The chest X-ray is about 60% accurate in differentiating pneumonia from a non-pneumonic acute respiratory distress syndrome. Complications of pneumonia may include cavitation and parapneumonic effusion, and if you inject contrast material, pneumonia will show either mild or no enhancement, and hypoenhancement or no enhancement may indicate the development of necrotizing pneumonia. And these are two batches of pneumonia consolidation, one in the right upper lobe, and the other one in the left lower lobe. And here is a classic presentation of left lower lobe pneumonia. You see an ill-defined patch in the left lower lung zone, and also you can easily appreciate the well definition of the cardiac shadow, which indicates that this opacity is posteriorly located, and any posteriorly located opacity in the chest will be in the lower lobe. Then you see here there is some obliteration of the costophrenic angle, maybe by mild pleural effusion, and this is the consolidation, and this is the cardiac shadow. And you remember that we call this the silhouette negative sign. Another example of pneumonia in the middle lobe, you cannot follow the cardiac border, and this is silhouette positive sign, indicating that the pneumonic consolidation is anterior, and the anteriorly located lung lobe here is the middle lobe. Then this is also a classic appearance of upper lobe pneumonia with some loss of volume as indicated by elevation of the horizontal fissure. You can easily also appreciate the presence of internal air bronchogram. And this is another example of upper lobe pneumonia on the right side, lower lobe pneumonia on the left side, and you got some atelectatic bands in the right lower lung lobe. And this is a pulmonary opacity which was secondary to pulmonary embolism, meaning that this is an infarction. And the infarction, as you remember, looks exactly similar to the pneumonic consolidation in the chest X-ray. Both will show air bronchogram. Both will be associated with pleural effusion. But it is the history and maybe the CT pulmonary angiography that can differentiate between pneumonia and infarction. But in both conditions, the central breakdown may occur in this area of consolidation, and an abscess may develop like this one with thick wall and internal air fluid level. And this is the right upper lobe pneumonia with a central breakdown developing into an abscess. Actually, we used to diagnose pneumonic consolidations in the upper lobes with internal cavitation as the sequelae of TB, because TB is one of the endemic diseases in our country, but still there are other possibilities like staphylococcal pneumonia, Klebsiella, and others. Then this patient with worsening dyspnea and pleuritic chest pain as well as hemoptysis after therapy or failed therapy for a community-acquired pneumonia. Then you see the pneumonic consolidation, and the follow-up study showed the progression of the disease with obliteration of the whole left hemithorax. Then the CT scan showed that there is fluid in the pleural cavity and associated compression of the left lung. most of the left lung. And if you look carefully, you can see that the margins of the collection or the pleural surfaces are enhancing, indicating that it is infected, diagnostic of the development of empyema. And this is an example of an abscess complicating pneumonia. This is the patchy consolidation in the right lower lobe with development of central breakdown, then the development of a well-formed abscess with internal air fluid level, and the follow-up after treatment showed almost total regression of the abscess. Then this is the appearance of the lesion at this stage, where the mnemonic consolidation has started to develop internal areas of breakdown as well as air loculi. Then we came to the pulmonary edema, which is one of the known lesions in ICU patients. We have two types of pulmonary edema: the hydrostatic edema, which is due to the cardiac problems, and increased permeability edema. Each of these types of edema may have some characteristic appearances on the chest X-ray and CT scans, but sometimes, according to the literature, both types of edema may coexist. Then the hydrostatic edema is the sequelae of left-sided cardiac strain, and it has well-known manifestations in the chest X-ray, which include enlargement and haziness of the hilar shadows, distension of the upper lobe vessels, and the appearance of B and A curves lines, the thickening of the interlobar fissures, the development of pleural effusion, the enlargement of the cardiac shadow. Then the classic findings of hydrostatic pulmonary edema include bilateral and symmetrical appearance of wide vascular pedicle, enlargement of the central hilar shadows, pulmonary venous vascular congestion with upper lobe blood vessel diversion, peribronchial coughing, subpleural interstitial edema, interlobal septal thickening, ground glass opacities, and eventually consolidations may develop. In cardiogenic pulmonary edema, the consolidation is dependent, meaning it is somewhat in the lower lobes. The cardiomegaly, the cardiac shadow is enlarged, pleural effusion may be present. If unilateral effusion, the effusion will be on the right side. In non-cardiogenic pulmonary edema, consolidation is diffuse or peripheral. Septal lines are not common, and the heart size are usually within normal. And this is an appearance of a patient with intracranial hemorrhage and obstructive hydrocephalus. Then the chest X-ray showed extensive bilateral pulmonary opacities, giving the classic appearance of the bat's wings sign. Then in this case, the diagnostic possibilities may include edema or pneumonia or hemorrhage. But the clinical history of the intracranial hemorrhage in this ICU patient with no septic markers, no fever, and so on, are diagnostic of non-cardiogenic pulmonary edema. But actually, in the radiology practice, we do not usually do much effort to differentiate between both types of edema because the differentiation mainly relies on the clinical and laboratory findings. But our main interest here is to diagnose the the event of pulmonary edema actually, and we try, supported by the clinical findings, to exclude other possibilities like infection and hemorrhage. And this patient had a progressive difficulty in ventilation, and they see the extensive pulmonary opacities with some of the septal lines. Then uh, actually, in ICU patients, if they develop edema due to cardiogenic causes, they do not usually need the help of CT, and the chest X-ray is quite sufficient. But if chest X-ray is performed, it will help in identification of the distribution of the pulmonary opacities. It can also detect pleural effusions that are subtle and cannot be detected by the plain film. And this patient with cardiac arrest showed, let us say, asymmetry in the pulmonary opacities, being much more evident on the right side. And you remember that this may be due to the frequent cardiac malposition while taking the radiograph, which is a common finding in the ICU patients. And the CT scan of the same case showed extensive bilateral ground glass opacities on both sides of the lung fields, and you may identify also the septal lines. Uh, Actually, if we have the section of that is passing through the pulmonary artery, we can assess this finding. But if you look here in this coronal image, and you can see that the right pulmonary artery as well as the left one are dilated. This is a post-operative patient with development of pulmonary edema, and you see the extensive opacities, and you see also the opacities on the CT scan. One of the causes of non-cardiogenic pulmonary edema is the high altitude edema, and the chest X-ray showed almost similar appearance to the previously displayed chest X-rays of pulmonary edema. Another case of extensive pulmonary edema, which actually, if you look to this film in the daily practice, and you are not supported by the clinical data, then this appearance is liable for a lot of differential diagnoses, including edema, infection, hemorrhage, and other diffuse patterns of pulmonary opacities. Then this patient is exposed to an acute near drowning incident, and this is the edematous changes in the lung with extensive ground glass opacities bilaterally distributed. Then the non-cardiogenic pulmonary edema is the result of bilateral extensive airspace opacities, and these opacities may progress to a diffuse distribution, and the opacities of extrapulmonary causes tend to be symmetric, diffuse, and homogeneous, while those of pulmonary causes may be asymmetric and patchy. Air bronchogram is present, and the septal lines and the permeability edema are uncommon. The heart and the pulmonary vasculature are usually normal. In order to remember the causes of permeability edema, that they are not related to cardiac problems, then you remember this abbreviation, not cardiac. Near drowning, oxygen therapy, transfusion, CNS problems like which is known as neurogenic pulmonary edema, allergic alveolitis, renal failure, drugs, inhaled toxins, high altitude, and pulmonary contusions secondary to trauma. Then permeability edema is due to diffuse alveolar damage of any underlying cause. This permeability edema affects any age group, including the pediatric age group. Patients are often intubated because of the severe respiratory distress. And you got within few hours patchy ground glass opacities, which will progress to consolidation, and the opacities are located in the dependent regions of the lung. Then I have mentioned some of these etiologies of permeability pulmonary edema, which are almost the same causes for the acute respiratory distress syndrome, and some include neurogenic causes, sepsis, burns, acute pancreatitis, drug intoxication, disseminated vascular coagulation, and inhalation of toxins, massive viral pneumonia, fat embolism, near drowning, and massive aspiration of gastric contents. These are the expected findings on imaging. Number one, there is no cardiac enlargement, no pleural effusion, no B-Curls lines. Air bronchogram is present, and the onset of changes in the chest X-ray and CT scan may be delayed up to 12 hours after the insult. Then from 12 to 24 hours, you got patchy alveolar opacities, and then up to 48 hours, you got massive areas of consolidation, and within 7 days, you got some clearance of the opacities, which is usually related to ventilation rather than true healing. After 7 days, the opacities may cause fibrosis, and you got some permanent lung damage. In the course of the disease, pneumonia may be superimposed, and the suggestive findings for superimposed pneumonia are in the imaging, new appearance of other opacities, and the development of pleural effusion. These lesions may be subjected to continuous positive airway pressure ventilation, which is known as CPAP, and this ventilation carries some risk problems, which include pneumothorax, pneumomediastinum, and pulmonary interstitial edema. And this will lead us to the issue of barotrauma, which is an abnormal collection of air in the chest. And this means in the lung, in the pleura, or in the mediastinum. Up to 15% of patients on ventilation develop barotrauma, and the lung diseases will increase the risk of the development of barotrauma. The effects of barotrauma are more severe in children and young adults. The initial accumulation of air will occur within the lung parenchyma in the form of interstitial edema. Then you got in the chest X-ray, in the CT scan, on this accumulation of air within the lung parenchyma is difficult to be detected by chest X-ray unless the loculi of air are sizable. then these accumulations of air may resolve or persist or become super infected with the development of multiple air fluid levels. Pulmonary interstitial edema has a risk of pneumothorax in about 77% of the cases. Pneumothorax is the most concerning sequelae in cases with barotrauma. Pneumothorax is seen in about 25% of ventilated patients, and it's often associated with pneumomediastinum, but pneumothorax is not caused by pneumomediastinum. On the chest X-ray, the pneumothorax may be missed, especially if it is a small pneumothorax, and uh, actually it is difficult to put the patient in the decubitus position, but sometimes you can use the expiratory and inspiratory films to be sure, as I have mentioned before. But these are also should be considered some underlying causes that may give false impression of the development of the presence of pneumothorax, like a skin fold or overlying tubes or dressing or tubes or lines, and the presence of prior chest tube tracts, like the intercostal tube, for example. Then a small pneumothorax, if there is a small pneumothorax and the patient is on ventilation, there is a great risk that this pneumothorax will increase and may develop tension pneumothorax in about 60 to 95% of the cases. Then in ICU patients, mediastinal shift is not always present. You remember that for the diagnosis of tension pneumothorax, we may have two main findings. Number one is the deviation or contralateral shift of the mediastinum, and number two is depression of the diaphragm. But the mediastinal shift in tension pneumothorax may be sometimes masked by the positive end respiratory pressure, which is the pressure in the lung above the atmospheric pressure that exists at the end of expiration. The signs of tension pneumothorax in ICU patient: displacement of the anterior junction line, the junction line between the two lungs, displacement of the zygoesophageal recess, and the flattening of the heart or the vascular shadow. Also, an important pneumomediastinum may be associated with pneumothorax, and you should search for this, as I will mention now. And this is an appearance of bilateral pneumothorax, and you can see it on both sides. And also you see the intercostal tubes that are inserted for drainage of the pneumothorax. If you look carefully here, you can appreciate the presence of a pleural line in this area and the divide or the absence of lung markings in this part, which is an indication of the presence of a small pneumothorax. And this is the lines which help you to appreciate the findings in the plain X-ray. Then you remember also the deep sulcus sign in the supine chest X-ray in patients with pneumothorax. Then if you see that there is a deep costophrenic angle, this indicates that there is a pneumothorax in this site. And this is a tension pneumothorax with subtotal collapse of the lung, some shift of the mediastinal structures, and some flattening of the diaphragm. And this is also a tension pneumothorax with a subtotal collapse of the left lung and evident air in the pleural space, and you can also appreciate the deep sulcus sign. And this case, the patient with symptomless right-sided tension pneumothorax. This is a case from the literature, and the patient denies any symptoms, and the mediastinum, as you can see, is shifted to the left side. The lung is markedly compressed by the pneumothorax. The patient came for a checkup 1 week after removal of a chest tube, and the patient denied any symptoms with no pain, no dyspnea, and normal respiratory rate. Then this is the tension pneumothorax, where you got partial atelectasis or compression of the right lung and some shift of the mediastinal structure. And in this case of a patient with a coughing fit, developed extensive surgical emphysema or subcutaneous emphysema with air in the mediastinum. And I think that one of the best diagnostic signs for the presence of air in the mediastinum, beside the well-known sign of continuous diaphragm, is the presence of air in the root of the neck. And this is one of the easily identified sign in the chest X-ray. Then also the continuous diaphragm sign, that you are able to follow the diaphragm all through, even in the area of contact with the cardiac shell. The causes of pneumomediastinum in ICU patients are spontaneous injury to the lung by the devices, extensive vomiting, the ventilation, chronic obstructive pulmonary airway disease and interstitial lung disease, forcible cough due to asthma or other causes. And these are sometimes, they said in the literature, it may be difficult to differentiate between pneumopericardium and the pneumomediastinum using the chest X-ray. But I think that one of the helpful signs for pneumomediastinum is the presence of air at the root of the neck. The continuous diaphragm sign means that you are able to follow the diaphragm, especially in the area where the heart is in contact with the diaphragm. And this continuous diaphragm sign can be easily appreciated in cases of pneumopericardium and also pneumomediastinum. But here, and you can see the continuous diaphragm sign, and if you look carefully here, and you see the air tracking in the root of the neck and also in the subcutaneous area, and this is a good sign for pneumomediastinum. Continuous diaphragm sign and some air in the root of the neck are helpful diagnostic signs for pneumomediastinum. Of course, if you have the CT scan, it's easy to appreciate the presence of air in the mediastinum, and is also easy to differentiate between air in the pericardium and air in the pneumomediastinum. There are some other signs that are somewhat difficult to appreciate in the plain film, like the double bronchial wall sign, which means that you can see air outside the bronchial wall and the air inside the bronchus, which is normal. But I think that the identification of air at the root of the neck is one of the good signs for the diagnosis of pneumomediastinum. And this is a patient which is subjected to a fall event, and they got some opacification in the right lung, which is attributed to pulmonary contusion. And in this example, you can easily appreciate the sign which is known as the continuous diaphragm sign, supportive of pneumomediastinum. Then we came to the pleural effusion, which is one of the common findings in the ICU patients, and the incidence may reach up to 62%. The 40% of effusion are detected at admission, and 90% of effusions are of the small size. These are the causes of effusion: parapneumonic, malignancy, empyema, embolism. And the transudative effusion is due to heart failure, volume overload, hypoalbuminemia, and uremia. As you see in this picture, the ultrasound is considered one of the best imaging modalities that can be used in ICU. The ultrasound is an easy, rapid technique, and is real time, and can go to the patient in bed, and can use the Doppler facility to image the vessels as well. Ultrasound is capable of diagnosing any pulmonary lesion or mediastinal pathology or pleural lesion, considering that the one who is holding the probe is efficient. And this will contribute much for the imaging of patients in the ICU units, and may decrease markedly the need for CT. And in the previous days, when you suspected the presence of pleural effusion, especially if you have the lateral view, which is not commonly performed for the ICU patients, and you see that the fluid collects in the posterior costophrenic angle, which is more deep than the lateral costophrenic angle. And we used to do the lateral decubitus film to see that the pleural fluid is trickling into the pleural space. But ultrasound is an excellent modality for detection of minimal pleural effusion and to assess the presence of secondary infection, like the development of empyema, the assessment of the development of fibrinous septations within the effusion after some time. The ultrasound is a remarkable imaging modality for these particular indications. And this is a mild pleural effusion, bilateral, showing the classic sign, which is known as the meniscus sign, the concavity of the upper surface of the fluid, and the raising edge towards the axilla. And this patient with moderate pleural effusion, she is known to have breast cancer and performed right radical mastectomy, and the chest X-ray showed the presence of pleural effusion. She is receiving chemotherapy, and according to the literature and according to the usual rules, a development of pleural effusion in a cancer patient may raise the possibility of metastasis to the pleural surfaces, and this was confirmed by ultrasound guided needle biopsy. This patient had nephrotic syndrome secondary to amyloidosis, and he developed recurrent right-sided pleural effusion, which necessitates the treatment by talc fluorodesis. And after that, they insert a catheter, and the catheter drained the effusion with no recurrence, indicated that there is pleurodesis, which occurred spontaneously after the trial for talc pleurodesis. And this is a chest X-ray in a patient with severe pancreatitis, intubated and ventilated in the ICU. The chest X-ray requested for assessment of the nasogastric tube position and the changes of air entry on the right side. Then if you look to this chest X-ray, which is actually markedly rotated, then you can see that there are two central venous lines. One is inserted in a good position in the distal part of the superior vena cava, or approaching the right atrium, and the second one is present with its tip near the clavicular level. Then if you look to the nasogastric tube, and the tube is in its usual site, and you can see some veiling opacity in the left lung base, which was due to a pleural effusion that was confirmed by CT scan, and you see the effusion with underlying compression consolidation. And this is a parapneumonic effusion, and you know that pneumonia and infarction may be associated with pleural effusion, and this is pneumonic effusion, pneumonia in the left lung, and parapneumonic effusion obliterating the left costophrenic ankle. And pulmonary embolism is also one of the lesions that may occur in the ICU patients, and they may be completely silent. And we have been taught previously that pulmonary embolism is an acute case with acute presentations, especially if the embolus is a little bit sizable. But we have seen cases with significant pulmonary embolism that are not so much distressed. The symptoms are non-specific, including dyspnea, tachypnea, hemoptysis, hypoxemia, and chest pain. The risk factors are due to previous embolic event, immobilization, trauma, surgery, shock, obesity, pregnancy, polycythemia, antithrombin 3 deficiency. Then the sensitivity of the plain X-ray for the diagnosis of pulmonary embolism, as you all know, is very low. And all what you can see in the chest X-ray are almost non-specific, including the presence of subsegmental atelectasis, the presence of some elevation of the ipsilateral diaphragm, the presence of enlargement of the pulmonary artery on the site of embolism, or you may see multiple areas of consolidation due to recurrent embolic episodes. The pleural-based consolidation, which is usually triangular in shape with the base outside and the apex inside, is often called Hampton-Hump sign. But this is not usually evident in most of the cases. An associated pleural effusion is a well-known finding in patients with pulmonary embolism. And here is what we call the Hampton-Hump sign, where you got a triangular opacity in the lung base usually, and its base is towards the pleura, its apex is towards the mediastinum. This may represent a pneumonic patch and may also represent an infarction. The decisive issue in these cases is the clinical picture and other laboratory and CT findings. And also here you can see this pulmonary opacity in the left lung base, and you can see the obliteration of the costophrenic angle by pleural effusion. We are not allowed as a radiologists to diagnose this as an infarction unless we have adequate supportive clinical data and the laboratory findings. Then if you have the CT scan and you can see the filling defect of the emboli within the vessels, then you are sure that you are dealing with pulmonary infarcts. And this is what we call an atelectatic band. There is some elevation of the ipsilateral diaphragm, and these are not sufficient findings in the plain film to diagnose pulmonary embolism, but here you can see the filling defect in the pulmonary artery, which can help you to or support your diagnosis. Then this patient with right pleuritic pain and mild dyspnea, and you see some opacity here near the costophrenic angle. The chest X-ray, the CT scan showed the opacity near the costophrenic angle and the bilateral filling defects in the pulmonary arteries representing pulmonary emboli. Then the superior vena cava obstruction is now one of the frequent findings in patients in the ICU unit, and the major underlying cause is the central venous catheters, which are frequently inserted because of they are frequently occluded, and they are replaced many times. Then this will result in thrombosis of the superior vena cava, and later on it may be totally occluded. And according to the literature, the major causes of superior vena cava obstruction are malignancy, and the most common, of course, is the bronchogenic carcinoma. Then you consider the central venous catheters, the pacemakers, and the disease known as fibrosing mediastinitis. Basic disease is one of the known lesions for superior vena cava obstruction. Then if you have the CT scan, it is easy to diagnose a superior vena cava obstruction by the absence of enhancement of the superior vena cava with a filling defect inside its lumen. But the plain film findings of broadening of the superior mediastinum and so on are not considered as diagnostic signs, of course. Then and the CT, of course, is the best one for evaluation of superior vena cava occlusion. And you see that the superior vena cava is not opacified by contrast material denoting its obstruction. And this is a case of iatrogenic superior vena cava obstruction due to repeated central venous catheter insertion. And here you see the enhancement of the aortic arch, but you cannot see the enhancement of the superior vena cava. Instead, and you see multiple dilated collaterals in the mediastinum and also in the chest wall. This is one of the ways to overcome the superior vena cava syndrome due to obstruction, is to put a stent within the superior vena cava to maintain its patency. Finally, we came to the cardiac tamponade, which means that there is limitation or restriction of the cardiac activity due to the presence of fluids or pus or blood or gas or neoplastic tissue within the pericardial cavity. Rapid or gradual accumulation will impair the cardiac output, and pericardial effusion may be very large but does not necessarily impair the cardiac function. We have a triad, which is known as the Beck triad, consisting of muffled heart sounds, hypotension, and the distended neck veins. Then, if you look to the chest X-ray, you see that the transverse cardiac diameter is enlarged and that the heart is flask shape, as we have been told previously, and this may indicate the presence of a fluid in the pericardium, and the diagnosis is usually pericardial effusion. But in the current practice, we usually use the echocardiography, which is of much help in assessment and the diagnosis of the fluid in the pericardium, and also to assess the possibility of cardiac tamponade. Then echocardiography is helpful in assessment of the size of pericardial effusion, and if it is loculated or not, and the evidence of hemodynamic compromise, like the presence of right atrial collapse, the presence of right ventricular diastolic collapse, the respiratory inflow variation across the mitral and the tricuspid valve, and also the assessment of the inferior vena cava, which is usually dilated uh, and unreactive to respiration in cases of tamponade. Then these are easily appreciated findings on echocardiography. But also the CT scan may be of help, but you remember that echocardiography is a simple procedure. The machine can go to the patient in the ICU unit, and you have the Doppler facility, you have the ultrasound imaging, the usual ultrasound, which can show also pulmonary changes and pleural effusion as well. Then the CT may help in assessment of the presence of pleural pericardial collection, and also the presence of associated pleural collection. The CT signs of cardiac tamponade are non-specific. They include distension of the superior vena cava, which may reach the caliber similar to the adjacent aorta. Also, distension of the IVC, which may be greater than the adjacent abdominal aorta. Hepatic and renal vein engorgement, periportal edema. There is a halo of hypodensity surrounding the portal venous branches in the liver. The flux of contrast material into the IVC or the azygos vein, compression of the coronary sinus, angulation or bowing of the interventricular septum. Sometimes you can see that this septum is bowed or angulated. Then you got pericardial thickening, collapse of the right ventricle, and this is the site of the right ventricle is clearly identified during echocardiography, and the aortic blood contrast level, you see like a fluid level within the aorta. In this case, you see big amount of fluid within the pericardium, and you see the sign of uh, kinking of the interventricular septum. Also, you see the distension of the IVC, which is 2 or 3 times the caliber of the adjacent aorta, distension of the right renal vein, and the periportal edema as hypodense halos around the portal venous tracts. And this is what we call the contrast level of the in the aorta. And also you got massive pericardial collection, and you got opacification or simultaneous opacification of the IVC and the aorta in the arterial phase. Sometimes cardiac tamponade can occur secondary to the presence of air within the pericardium, and this is known as tension pneumopericardium. And this pneumopericardium is associated with bilateral pneumothorax, which is big, relatively big on the left side, and small on the right side. And this is also pneumopericardium. And you see by plain X-ray and by CT the accumulation of air within the pericardium. And this is what we call hydropneumopericardium. You got fluid as well as air fluid level within the pericardium, and the CT scan showed the presence of fluid and air within the pericardium. But in echocardiography, there was a massive pericardial effusion causing more than 25% respiratory variation of the mitral inflow, which is diagnostic of cardiac tamponade. That's to say, for easy and rapid diagnosis of cardiac tamponade, it is echocardiography which will be of help. Thank you very much. Alhamdulillah.